Welcome. In this session, we'll be discussing about acquired retinal macroaneurysms. Acquired retinal macroaneurysm, as seen here in this clinical photograph, is a focal, fusiform or saccular dilatation of retinal arteriole in the posterior fundus within the first three orders of retinal arteriolar bifurcations. Typically, they are located at arteriolar bifurcations or at arteriovenous crossings and most commonly involve the supratemporal artery. Macroaneurysms cause loss of vision from exudation, hemorrhage or embolism involving the foveal region. Acquired retinal macroaneurysm occur in 6 to 7 decades of life and females are more commonly affected than males. 90% cases are unilateral, but multiple aneurysms may occur in the same eye. Acquired retinal macroaneurysms are associated with systemic arterial hypertension and cardiovascular diseases, and this is important to remember. Histopathological examination shows gross dilatation of involved retinal arteriole with adjacent areas of capillary dilatation, fibroglial proliferation, extravasated blood, hemosiderin deposits, and lipid exudates. Loss of vision in an eye with acquired retinal macroaneurysm can occur due to edema, exudation, hemorrhage, and embolism from the macroaneurysm involving the foveal region, and in this clinical photograph we see hemorrhaging and exudation from this retinal arterial macroaneurysm. Hemorrhage from macroaneurysm leads to sudden diminution of vision, while exudation from a macroaneurysm leads to slow decline in vision. On clinical examination, the macroaneurysm may be visible as a focal reddish dilatation in a retinal arteriole, and 10% of macroaneurysms appear pulsatile on clinical examination. Following rupture and hemorrhage from the macroaneurysm itself undergoes thrombosis, and after resolution of this hemorrhage, the causative macroaneurysm may be difficult to detect, but a focal kink in the arteriole may indicate the location of the previously ruptured macroaneurysm. Hemorrhage from the macroaneurysm can occur within the retina, the subretinal space, the sub-ILM space, and into the vitreous cavity. It has been found that hemorrhage occurs more commonly from saccular macroaneurysms near the optic disc in patients with high systolic blood pressure, and the hemorrhage can partially or completely obscure the macroaneurysm itself. Subretinal hemorrhage appears dark and so may mimic a melanotic tumor. Exudation from a macroaneurysm usually surrounds the macroaneurysm in a sarcinate pattern as seen here in this clinical photograph, and it has been found that exudation is more common from aneurysms which are fusiform in shape. Retinal macroaneurysm can lead to retinal ischemia from thrombosis and embolism, and retinal vein occlusion in the territory supplied by the involved retinal arteriole, and a macular hole may form following rupture of a macroaneurysm. Retinal macroaneurysms occurring along with retinal vasculitis and neuroretinitis constitutes the IRVAN syndrome, IRVAN standing for idiopathic retinal vasculitis, retinal arteriolar macroaneurysm, and neuroretinitis. IRVAN syndrome affects young to middle-aged individuals, and aneurysms of IRVAN syndrome can occur at retinal arterial bifurcations on the optic nerve head, which is unusual for senile acquired retinal arterial macroaneurysm, and exudation resembling neuroretinitis as seen here in this clinical photograph occur mostly adjacent to the macroaneurysms in IRVAN syndrome. Multiple aneurysms on a single retinal arteriole is a characteristic of IRVAN syndrome, and eyes with IRVAN syndrome can have cells in the anterior chamber and the vitreous cavity. And although inflammation of IRVAN syndrome reduces with corticosteroids, significant visual improvement does not occur in IRVAN syndrome with corticosteroids. On fluorescein angiography, hemorrhage from the macroaneurysm appears as block fluorescence as seen here in this fluorescein angiogram corresponding to this location of hemorrhage in this clinical photograph, and the macroaneurysm itself fills in the early arterial phase of the angiogram and appears hyperfluorescent. The filling of the macroaneurysm may be complete or incomplete based on presence of a thrombus within the macroaneurysm. Later frames may show leakage from the macroaneurysm and staining of its walls. Significant hemorrhage may obscure the macroaneurysm, and in this situation, ICG angiography may be able to reveal the macroaneurysm, as wavelengths used in ICG angiography can penetrate blood more efficiently. The involved arteriole appears narrow proximal and distal to the macroaneurysm and adjacent to the macroaneurysm. There can be a zone demonstrating widening of capillary free zone, capillary dilatation and leakage, capillary non-perfusion, microaneurysms, and artery to artery collaterals. Video ICG angiography may show the pulsatile nature of the macroaneurysm. OCT may show an unruptured aneurysm as a round lesion in inner retinal layers with thick hyperreflective walls and a dark lumen. The lumen becomes hyperreflective following laser photocoagulation due to thrombus formation. OCT may show associated hemorrhage and lipids as hyperreflective dots and associated intraretinal edema as hyperreflective spaces. Initially, the layers of the retina appear preserved, but they may become disrupted or lost later in the disease process from significant hemorrhage and exudation. Differential diagnosis of acquired retinal macroaneurysms include retinal telangiectasia of Coats disease and macular telangiectasia type 1, both of which have macroaneurysms as a clinical feature. Retinal capillary angioma of von Hippel-Lindau disease, retinal cavernous hemangioma, malignant melanoma and hemorrhagic PED, and capillary dilatations in diabetic retinopathy and branch retinal vein occlusion. Treatment protocol of acquired retinal macroaneurysm is not well defined, and it has been found that without treatment, thrombosis occurs within the macroaneurysm, followed by its involution and spontaneous resolution of hemorrhage and exudation. But significant hemorrhage and exudation can disrupt the retinal layers as we have described. Predominantly hemorrhagic macroaneurysms have a better visual outcome as compared to predominantly exudative macroaneurysms. Similar final visual outcomes have been found with and without treatment among eyes with acquired retinal macroaneurysm, and so initial management can be observation with institution of treatment if exudation increases during follow-up, and systemic workup for hypertension and cardiovascular diseases is recommended. Laser photocoagulation of the macroaneurysm is the primary treatment modality, and it is indicated when exudation involves the fovea. Predominantly hemorrhagic macroaneurysms are usually not treated, and during laser photocoagulation, either the macroaneurysm is treated directly or it is encircled by 2 to 3 rows of laser burns as seen here in this clinical photograph. Laser photocoagulation of the macroaneurysm may occlude the involved arteriole, and so laser photocoagulation should not be done if the portion of the involved arteriole distal to the macroaneurysm supplies the fovea, and this is important to remember. In eyes with submacular hemorrhage, pneumatic displacement with or without prior intravitreal tissue plasminogen activator can be attempted. Nd:YAG laser application to drain subhyaloid hemorrhage has been described, but this may lead to macular hole formation, arterial occlusion, and epiretinal membrane formation. Intravitreal bevacizumab injection in eyes with acquired retinal macroaneurysm has been shown to result in faster resolution of hemorrhage and exudation with better final visual acuity. To recap the salient points, retinal arteriolar macroaneurysm is a focal dilatation of retinal arteriole in the posterior pole within the first 3 orders of bifurcation of the retinal arterial system. Retinal arteriolar macroaneurysm cause loss of vision either by hemorrhage or exudation involving the foveal region. They are usually unilateral, have a female preponderance, occur in 6 to 7 decades of life, and are associated with systemic hypertension and cardiovascular diseases. Patient may present with either sudden loss of vision from hemorrhage or gradual loss of vision from exudation. Examination may show the macroaneurysm as a focal red dilatation in the involved arteriole. It may be partially or completely obscured by hemorrhage, which may be retinal, subretinal, or preretinal. Exudates usually appear as a circinate ring surrounding the macroaneurysm. Fluorescent angiography shows early filling of the macroaneurysm and blocked fluorescence from the zone of hemorrhage. With significant hemorrhage, ICGA may be able to detect the macroaneurysm. Differential diagnosis include retinal capillary hemangioma, retinal cavernous hemangioma, macular telangiectasia, hemorrhagic pigment epithelial detachment, malignant melanoma, and capillary dilatations of diabetic retinopathy and branch retinal vein occlusion. Treatment modalities include laser photocoagulation of the macroaneurysm when exudation involves the fovea, and pneumatic retinopexy with or without tissue plasminogen activator for submacular hemorrhage. Intravitreal bevacizumab has also shown faster resolution of hemorrhage and exudation with better final visual acuity. Thank you for listening.